Good morning. This is Open Mics with Dr. Stites. I'm Alexis Del-Cid, filling in for Dr. Stites today. You know, most of the time when you walk into an emergency department or urgent care clinic, you get treated and then you walk right out and you go home. Not always, though. Sometimes you unexpectedly wind up in surgery. That's what happened to the man you're about to meet. His gut pain led to emergency gallbladder surgery, and while he'd never had anything like it happen to him, the surgical team that treated him is prepared for situations like that 24/7. And joining me in the studio today is Dr. Jennifer Hartwell, an acute care surgeon here at the University of Kansas Health System. She's also the section chief of emergency general surgery. And we also have Mary Perry. Mary is a critical care nurse and the emergency general surgery program coordinator. Thank you both for making time to be here. I know you're extremely busy. We're also going to speak with one of your patients in just a moment, the man we were just talking about. And we're going to talk about the new COVID vaccine recommendations with Dr. Dana Hawkinson joining us in just a few moments. We'll get to you in a minute, Hawk. But first, Mary and Dr. Hartwell, we want to ask about the recent recognition that your team received. It's pretty cool. You helped set the bar and made the University of Kansas Health System one of the first 5 hospitals in the country to have a verified emergency general surgery program. That's set by a national group, so congratulations, the American College of Surgeons. I want to start with Mary. How did the program earn that verification? How does that happen?
So KU was selected as one of the pilot sites for this verification, and the American College of Surgeons actually came to a virtual site visit, and they assessed how we do our performance improvement initiatives, how we treat these emergency general surgery patients, and provide our overall care to this patient population. Using what they found at our site visit, they actually helped to create the standards for this national program. And so we helped to set the bar for not only areas or hospitals in the region, but for national hospitals across the country to meet this level of proficiency and exceptional care.
That's pretty remarkable that you not only get the recognition, but then they're using what you're doing here to set the standard for what other health systems and hospitals should achieve. So congratulations.
Yeah, thank you.
That's really cool. Dr. Hartwell, I want to get into this. How do you differentiate between emergency general surgery and then trauma surgery?
Yeah, sure. The way I like to describe it is patients can often identify themselves as a trauma patient because they know I've been in a car accident or I had an injury at work, and they recognize that they may be a trauma patient because of the nature of their injury. People who have emergency general surgery conditions just know they don't feel well.
Right.
They may have pain, and so they come to the emergency department, no idea what's going on, and so we are the ones who helped find that diagnosis. So emergency general surgery is really our team addressing surgical needs in a very timely manner. Things that patients can't go home and wait, they need to have surgery more urgently on this hospital admission.
Like what happened to Brett, and we're going to get to Brett in a moment.
Yes.
I want to also ask Mary, how do you identify those patients that need the emergency surgery?
From a programmatic standpoint, we have patients, like Dr. Hartwell mentioned, that present to the emergency department, usually about 70% of our patients. And our ED colleagues will triage them, and they'll find whatever diagnosis that the patient may be presenting with. And then at that point, they will be seen by our emergency general surgery team and go whatever path in order to get the care they need. From a programmatic standpoint, we have to do a lot of manual work on the back end, and because our program's relatively new, we do a lot of manual data collection, so I'm in front of the computer a lot, and tracking the patients from the time they come in through the ED or come to us from another hospital, and then I follow them through the whole stay, and sometimes even see how they're doing in our clinic when they come to our outpatient clinic as well.
And so once they're here, there are some unique needs that a patient would need that's in emergency general surgery. What would be those unique things that you're talking about?
Sure. So sometimes patients who come in for emergency general surgery have a lot of other medical conditions, and so we work very collaboratively with physicians throughout the hospital to address those needs. As emergency general surgeons, we are double board certified in general surgery and critical care, which means our team is uniquely poised to care for patients at their most critical needs, even in the ICU. So sometimes emergency general surgery patients have something that can be quickly treated through emergency surgery, but then we follow them all the way through their hospital course, including whatever needs they have, medical needs they have going forward.
And Brett sits. He's one of your patients. We have him on the program today, joining us remotely. He's one of those patients that fit that fit that bill. And I want to ask Brett, Dr. Hartwell, first of all, Dr. Hartwell, you removed Brett's gallbladder.
I did.
So is this the first time you're seeing each other face to face since then?
It is.
How does he look to you?
He looks amazing.
Look like he's been following doctor's orders?
Yes, I'm really happy to see him up and happy and smiling and saying that he feels good. That makes my heart warm.
Well, Brett, one of the things that struck me talking to you is that you're only 28. By all accounts, you were in great health until that one day you felt pain in your abdomen. So take us back to when that happened, what you were doing, and what did that pain feel like?
Yeah, so I work at the University of Kansas School of Law in Lawrence, and from the outset, so I came into work, it was late May, and I woke up with a sharp pain right in my upper right abdomen, and pain that I'd never felt before. It was really bizarre. It was unlike any pain I'd felt before. Basically, I could position myself in certain ways to where it wouldn't hurt terribly. But, as the course of the day went on at work, it got worse. So I presented to the health clinic here. They ran some blood work and things like that, but the doctor there that saw me thought it was likely my gallbladder and told me, if it got worse throughout the night, to present myself to an emergency room. And so lo and behold, I go home, and right as I'm going to bed about 10 o'clock, I look at my fiance, Sarah, and I go, this is terrible. It's excruciating. So she drove me to the University of Kansas Health System's main hospital, and I presented myself at that time.
So you walk into the emergency department. At what point did the doctors start to give you signs that something was very wrong?
It was, from what I recall, my ER experience was mostly fine. ER experiences are what they are at times, and I totally get that. It took a little bit to get admitted, back to the ER room in the back. But once I was back there, they started running tests. And it was really after the ultrasound that we found out that things were not great.
And we're going to get to that ultrasound a little bit more in depth, because you say that was excruciating in itself, which is where I want to bring in Dr. Hartwell. A lot of us have stomach pain. That's a very general symptom. So it's always scary when you hear that stomach pain leads to this or leads to that or leads to emergency gallbladder removal. How do you make that decision?
That's a great question. So sometimes we have clues, like in Brett's case, he had pain on the right side of his abdomen on the upper side, and that's kind of a clue that the gallbladder may be the problem. Patients who have pain on the right side, lower down, that's kind of a clue. It could be the appendix. So that sort of guides the testing that our emergency medicine colleagues do. But it's true that abdominal pain can be all kinds of different things. So we really rely on our emergency medicine colleagues to help narrow down the diagnosis, just like they did for Brett.
One of the things that we love about doing this program is when doctors are able to share medical imaging and things of that nature. And you gave us one of Brett's ultrasound images, so I want to put that up. To me, that just looks like a blob.
Yes.
So what are you seeing as a doctor that tells you there's something really wrong there?
Yeah, first I want to preface that ultrasound is a great tool that is quick and can be done very easily and doesn't subject the patient to radiation. So we use it a lot in the emergency department. And so what we're looking at, actually, that really dark area in the center of the screen is the gallbladder. And this is Brett's ultrasound, and it shows, in my eyes, that there's a little bit of thickening around the gallbladder. And that's our clue that the gallbladder is inflamed or infected. And that helps correlate that that's why he would have the pain. And then that's how we know that taking the gallbladder out will likely resolve that pain.
What causes a gallbladder to get inflamed or infected?
Yeah, great question, because people always ask, what can I do to prevent this?
Right.
And the answer is not much, unfortunately.
Oh, shoot, I hate that. Okay.
It just kind of happens. There's nothing that Brett did to cause the problem. There's nothing he really could have done to prevent it. It just sort of happens.
Luck of the draw.
Luck of the draw.
And Brett was saying that the ultrasound itself was painful. First, I want to ask, is that rare that an ultrasound is painful? In
Brett's case, it's very typical, actually, and it helps clinch the diagnosis because he had pain with the pressure, and Brett can address that. It's very, they put a lot of pressure on your belly to get that ultrasound.
Yeah, I want to start off by saying my technician was fantastic, and it was, in terms of what you said, Dr. Hartwell, I completely agree. It was actually a relatively quick process, but yeah, whenever she was pressing on my gallbladder region, that was some of the sharpest pain I've had in my life.
So you decide the gallbladder's got to come out.
Right.
So this is where bedside manner comes into play for the mere mortals that are there in a scary situation. How do you break the news to someone like Brett or anyone watching? You don't want to panic them, but you need to press upon them that you're going into surgery.
Right.
Is that something you practice in med school?
A little bit, but not really. It's something I've learned over time. And talking with patients like Brett, it's a critical moment, and I have just minutes to gain his trust that I am the surgeon who he's just met, and I'm telling him it's time to go to surgery, and I need you to trust me to be under general anesthesia and open you up and take out what's hurting you. So it's very important to me to work clearly and be concise and empathetic with my patients, because I only have a few minutes to build that trust, unlike patients who maybe have a long-term relationship with their primary care doctor or an elective or planned surgery. So it is hard, and I work really hard to gain that trust and build a quick relationship with the patients right before surgery.
Boy, that's a skill that you
it's taken years of practice.
Brett, what was it like being on the other end of that?
I am infinitely grateful for Dr. Hartwell and her team. I recall, meeting with her right before my surgery, and it's a little fuzzy because of all the anesthesia drugs I was on. But what I do recall is I was asking her a series of questions because it was my first surgery ever. And so I recall she answered everything clearly, and I got that sense of trust from you, Dr. Hartwell. So whatever you did, it worked great.
Yeah.
Oh, that's nice.
Great.
We want to give a shout out to your fiance, Sarah, Brett, because you've talked about how she was so key in getting you through this process. First of all, congratulations on being engaged. Tell us about Sarah. Where are these pictures taken?
Yeah, so the first one was from my law school graduation celebration. It was actually during COVID. So I graduated from law school in 2020 during COVID, and sadly didn't have a graduation because of it, but we celebrated on our own. The other pictures are, one was in Colorado, whenever my parents lived in Colorado, and then that one right there is a more recent picture of us that we took after my surgery. We went to Mexico about a month after.
That's another great thing to ask you about, because a month later you're on vacation with your fiance in Mexico. That's very reassuring to anyone who might need this kind of surgery. Talk us through what it was like, from you're going into surgery. The last face you see is probably Dr. Hartwell.
Mm-hmm.
Yeah.
And then you open your eyes, and what was the recovery like?
They always told me they didn't think it was going to be super prolonged based on the type of procedure they were doing. And Dr. Hartwell can correct me on that. I believe is it laparoscopic is what it's called. And yeah, and it was, I was back to work in 3 days.
Mm-hmm. Oh, wow.
Yeah.
I want to ask you about what is laparoscopic. That's a foreign word for many people watching.
Sure. So laparoscopic, the way I describe it, is we're able to use small scopes and cameras. So we're able to make little tiny incisions about 1 inch in size, 3 or 4 little incisions across the abdomen, so they heal up really well, and it keeps us from making a big incision. And we're able to use little instruments that are real tiny with cameras, and we're able to get the gallbladder. We do that for appendix, and many other surgeries are done laparoscopically. And just like Brett's experience, it helps patients usually recover a little faster. And so it's a great option for some patients to be able to have a laparoscopic case.
When you take out something like a gallbladder, once you take it out, can you clearly tell that it was a troublemaker? You're looking at it and it just looks like a bad acting gallbladder?
Yes, frequently we can. Every time we take something out, we send it to the pathologist just to take a good look at everything, make sure there's nothing surprising. But yes, and we could tell with Brett's gallbladder that it was inflamed.
Just naughty.
And yes, and it was clearly what was causing his pain.
Does any patient ever want to see it afterwards? Can they see it?
Yes, so we don't send the actual, we don't let them see the actual specimen, but we oftentimes take pictures. And patients frequently ask to see pictures, and so I was just in a case the other day, a patient asked to see pictures, and so we were able to take some pictures in the operating room and upload them to his MyChart, so he was able to see them.
Did Brett want it? Brett, did you want to see your gallbladder after it was out?
I did not.
Good riddance.
It just
Bye,
be
gallbladder.
Out and gone. Yeah.
You're just glad that little guy was gone. Yes. It must be so gratifying.
I was just happy the pain was gone. Yeah.
Right, absolutely. Get to go on vacation with your fiance, Sarah. It must be so gratifying to see patients after the fact.
Yes.
Smiling and healthy.
It is.
Indeed. I always tell my patients the best gift you can give me is to come back to our clinic or come back to the hospital, walk through the unit, high-five the nurses, let us see that you're doing well. Seeing a patient like Brett, like this is absolutely the greatest gift we have in healthcare.
Well, this is pretty special, and we know we have questions from our viewers. We love when you send us your questions. Remember, you can reach us everywhere. We're on YouTube, Facebook, the X platform. You can email the Medical News Network. We will ask your questions live during the program. And before we go any further, keep those questions coming. We do want to check in with Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control here at the health system. We want to check in with the COVID count. How many active patients are we treating this week?
This week we had 16 active patients, so up just a little bit from the big jump from under 10, 7 to 14, and then this week 16 active patients. So.
And is that something that you're surprised by, prepared for, you're feeling good about because you know you got it under control?
I think I'm optimistic and feeling better that it didn't jump higher than the 16 compared to 14 the week previous. Again, we still know it's out there. We know that a lot of, especially young kids, high school students, and probably younger students than that are getting it, missing sports, missing other activities because of it. And of course, they're bringing it home to their family as well. So we know it's out there. We know the virus is circulating. I'm happy that we only have 16 in the hospital, and we'll just kind of wait to see what the numbers are in the next few weeks as well.
Gotcha. We do have some big news from the CDC because yesterday a CDC panel of outside experts officially recommended that everyone 6 months or older get the updated COVID vaccine. Are you surprised that they included babies, kids, and healthy young adults in the recommendation?
Not surprised by it. I think we had thought that. I know Dr. Stites and I talked about that. We would have been surprised when we talked about, well, maybe they will make specific recommendations for specific groups like they have done for other vaccines in what they called clinical decision making. But when you read through and understand what their reasoning in, basically they said there is no group that clearly has no risk from COVID. And so especially if you haven't had the infection or had the last vaccine within the past year, when the first boosters rolled out, then it's important to get it. So yeah, overall, anybody 6 months of age up is eligible and recommended to get the vaccine. Now, what they also did say is that later on in the year, if you are immune compromised, you can get another dose, but they were vague about that. They didn't put any specific time frame on it. I think in the past it's been anything from 2 to 4 months previous. They also said that older people will probably be able to get one after they've got this first updated vaccine as well. But again, vague, no specific time frame. That may be coming out later.
One final question while we have you here. There's been a change in the wording the CDC is using. It stopped calling this a booster and instead calling it an updated vaccine. What does that mean?
Yeah, I mean, I think what that means is it probably will be with us for a while, just like the influenza vaccine. They are calling this the 2023-2024 formulation or updated vaccine. I think we can expect that moving forward. And again, luckily right now with the current more predominant variants in the United States, we know that the vaccine continues to have activity and provide good protection based on certain early lab reports, of course, but also based on the conserved areas and those areas that haven't changed too much. We know that Moderna just put out a press release saying that you do get some neutralizing antibodies after this booster as well. So overall, it does look good. And again, we remember that the vaccine is safe. Certainly for some groups, there may be a little bit higher risk of things like myocarditis for those younger aged males, but again, that is a transient thing. Typically is not severe, resolves on its own. And again, certainly the benefits of these vaccines do outweigh the risk, especially when you take into account things like long COVID, where we know vaccination can help reduce that as well. So,
are there any reporters on the line today? Any reporter questions? Okay, well, that's actually good news because we have lots of community questions. Let's get right to those. Yen Liang has a question right out of the gate for Dr. Hartwell. He asks us on Facebook, does a gallbladder polyp always require surgery?
Good question. Usually, When we see a gallbladder polyp, we do offer a patient to have the gallbladder taken out. At least a surveillance ultrasound would be required. It's not mandatory as soon as we see a polyp, but oftentimes the patients are concerned about that finding, and so for reassurance, we oftentimes offer them the gallbladder to come out. It's a common and safe surgery, and so we often just offer them to have the gallbladder out for peace of mind.
Mia Monarca has another question about gallbladders. She wants to know, does your diet change or should it after you have your gallbladder removed?
Excellent question. I remember talking to Brett about this as well. So the gallbladder, it stores the bile, which helps us digest fats. And so I usually tell patients, your liver actually makes the bile, and so you can go on to eat anything you want. But immediately after gallbladder surgery, I tell patients, spend a few weeks eating light meals, more bland food, and then slowly add back in foods that are spicy, heavy, greasy, because your body will have a little harder time digesting for the first couple of weeks. And then you can eat whatever you want.
Brett, what did you notice about when you started eating new foods after your gallbladder removal?
Just that. I stuck with bland foods for, it might have even been the first full month after, and slowly eased my way in. I'm still wanting to be careful with spicy foods. At this point, I feel like I probably could go back into it, but I started with bland, and like Dr. Hartwell said, just ease back into kind of my routine diet.
Were you able to have a margarita on your vacation with your fiance?
I was, yes.
Good. That's very important. Sarah needed to be treated.
Yep.
Brett, question from Joellen for Brett. Did Brett have gallstones, and is the saying for gallbladder issues, females over 40 and overweight, true? Mm-hmm. Okay, well, first of all, I want to ask you about the female thing, but Brett, did you have gallstones?
I don't believe so.
Okay. And then what about the females over 40 and overweight?
Yeah, so that was kind of a classic thing that we were taught in med school. That really doesn't hold true anymore. Okay. Anyone can get gallbladder issues. There really isn't necessarily a specific pattern there, and so we try to be very open-minded about any patient who has right upper quadrant pain, could be the gallbladder, and we don't pay much mind to that old phrase that we learned in med school many years ago.
Because Brett's a 28 young man who looks pretty spry, so he wouldn't fit that saying.
That's right.
Janet Corey has a question about vaccines. So this is for Dr. Hawkinson. Janet wants to know, Janet Coy rather, I need 4 different shots, Prevnar 20, RSV, flu, and then the new COVID shot. I'm confused on which to get first and the wait between shots. I can only use one arm for injections. So Dr. Hawkinson, what would you tell Janet?
Yeah, I mean, most of these you can receive at the same time. You can certainly get influenza and the COVID vaccine at the same time. You can also get the Prevnar. That is a totally different platform. So I think it's okay to get those. And the RSV, most of these you can get at the same time. I think if you're only using one arm, that's going to be really what is going to limit you. So if you're doing that, then I would limit at least 10 to 14 days between a vaccine. But if you can get a couple at a time, that is good. If you can get the 3 at a time, 4 may be too painful, especially if you have a small deltoid. But you should be able to get these at the same time. There is no recommendations for not getting them with these current vaccines. So certainly I know with my patients, we are able to give these, specifically the ones that you mentioned, at the same time in the clinic. Of course, we're going to be using different arms. But I think really in your situation with only being able to use one arm, that would probably be the most limiting factor. If you can at least get 2 at the same time, that's good as well. But there otherwise should not be any contraindications to receiving those.
Katie has a follow-up question to that. Any idea on when the health system will have the vaccine available to the public?
No, I think that's a good question. We didn't expect the overall COVID updated vaccine until the end of the month. And now with the most recent update and ACIP's recommendations, they're saying it'll be available in some places by the end of the week. We don't have any good data on when we will get ours, but hopefully within the next week, 10 days, 14 days, and we'll be able to administer. We're also currently awaiting our supply of the RSV vaccine as well, and when we have that, we'll be able to administer that as well. And of course, I don't believe influenza vaccine is out just yet either.
Terry has a question. I want to ask Mary about this. Got to give you some love here. You talked about how you have such an important job, and a lot of your job is working at the computer and managing and balancing things. So what's the caseload like in a typical week? How many surgeries and procedures are you navigating?
Yeah, thank you. So we track this. This is a data point that I collect on. And on average, our physicians and residents see about 25 to 30 patients per day. And then over the course of a week, there could be anywhere from 14 to 18 surgeries. As Dr. Hartwell mentioned, they operate any time of day, weekends, nights, you name it. And so there's a varying caseload and operations, but on average, I'd say around 14 to 18 cases per week for the service line.
That's a lot.
It is, yeah.
That is a lot. Orlando has a question for Dr. Hartwell. Orlando wants to know, oh, I love questions like this. What's the longest surgery you've ever been a part of?
So that's a good question. The longest surgery I've personally ever been a part of was when I was a resident, and it was an operation on the pancreas, and it took 8 hours.
And are you standing that whole time?
We are standing the whole time. So there's a team of surgeons who take care of a patient when a surgery is really long, and we're able to give each other short breaks because there's always surgeons available to help that patient. So we are able to take a quick break, go to the restroom, and get a drink of water.
That's what I was going to ask.
Yeah.
Like, what happens if you get an itch on your nose?
You just have to ignore it. Yes.
And do you have music that you listen to?
We do.
Do you have a playlist that you like for surgeries?
I do. I kind of like sort of mellow top 40, kind of easy music, nothing too crazy.
Right.
Yes.
Keep it mellow, keep it calm. Do you think that patients can, I always get asked this by my friends, they want me to ask the doctors, do you think patients can hear subconsciously what music is playing? Like, will he come out knowing a Taylor Swift song after his surgery?
I have had patients tell us that they have some vague recall of what they heard in the OR, and there have been times that I've asked a patient what music do they want to wake up to, so I can play their favorite song when they're waking up.
Nice.
Yes.
That's really nice. I want to bring our whole panel in because we'd love to get some final thoughts, and I want to start with Mary. What is your takeaway, and what do you most want our viewers to know?
I am just really proud to be one of the first in the nation to have this verification and to set the bar, set the standards for, as mentioned, not only patients that come to KU, but patients, future patients across the country will have some standard of care based on what we did here. And just really proud of that. Really thankful for the team. We mentioned our team, so it's not just Dr. Hartwell and I. There's nurses and physicians from the emergency department all the way through to even our clinic staff in the outpatient setting. So just really proud to work for the team and for this organization.
We love having you on, and congratulations on that certification. That is so cool.
Thank you.
So cool and nationally recognized. Dr. Hartwell, what would be your final message for our viewers, or for Brett?
Yeah. So I absolutely love my job. I love being at the ready 24/7 for patients like Brett who come in and need something urgently. And it's a gift to be able to see patients doing well. And so I would just say, if you have a need, you don't feel well, come in. We're ready to take care of you. We have a giant team that is totally prepared to take care of you, and it's our great honor to do that.
Brett, what's it like to be here now and be on the air with part of the team that really saved you?
Fantastic. I tell people like I mentioned earlier, I'm infinitely grateful for Dr. Hartwell, Nurse Perry, their entire team. It was a surreal feeling. Like what I recall when I woke up the first day and is like I was able to move and I didn't have pain, and it was fantastic, just a fantastic feeling. So I'm infinitely grateful. I had a terrific experience at the hospital and am just so happy to be feeling better.
Oh wow, what a great compliment. And shout out to Sarah again, fiance Sarah.
Yes.
She drove you here like a champ. She got you to the ER. And you want to give her a shout out too?
Stayed by my side the whole time.
That's right.
Yep. So
you're a great
I couldn't
team.
have done it without her either.
Oh, that's sweet. Well, thank you so much for being here, Brett, and thank you to Dr. Hartwell and Mary. We really appreciate you taking the time out of your busy day to join us, and thank you to our audience and all the great questions. We'll see you right back here tomorrow morning. Most of us wouldn't complain about an afternoon nap, but it was a sign something was seriously wrong with this man. I'm Alexis Del Cid on the next All Things Heart, how your sleep habits can impact your heart, and what a sleep study can reveal about your heart health. Thursday on All Things Heart.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.